All right, folks. Thank you for joining our Reese Education Series. Glad you guys are here. Today, we have Dr. Sabrina Kaplan, who is an emergency medicine and toxicology physician. She actually talked at MSAC in November, and it was a crowd pleaser. So I'm so excited to have her here today, and I will let her take it away.
Fantastic. And yeah, please interrupt me at any time, guys, if you can't hear, or if you have any questions. This is meant to be as helpful and interactive as humanly possible. So I was brought here today to discuss some substances of abuse that are popular right now and making the news. And I'm also here to discuss other favorites such as opioids, methamphetamine. We'll do a short bit about that as well. And if there's anything else at the end that I haven't discussed, please let me know and I can go into that as well. So first, this is my disclosure slide. No conflicts of interest, no relevant financial interests or relationships. And this is a QR code I can pause on briefly for everyone to scan and get credit for this. And I can come back to this at the end of the slides as well. All right. So first, we're going to go briefly into a little bit about fentanyl, which is my favorite subject because I actually entered fellowship wanting to study fentanyl and other synthetic opioids pretty much exclusively. So to the right, you'll see here are blue pills, which I'm sure you're all familiar with at this point. These are referred to as M30s, fentanyl blues, street oxy. They have a myriad of names, and they're basically a bunch of synthetic opioids that are pill pressed together, and then they have this insignia on top, the M and the 30 as well. So this is what we're seeing on the streets these days. So updates, not surprising, but still a major problem to say the least. Death rates are escalating. Synthetic opioids made up 88% of deaths from opioids in 2020, and these numbers just keep going up. And Colorado has similar trends. So this is just a graph to illustrate that. You can see that methadone is also a synthetic, but the rates of abuse from that have pretty much stagnated, and the synthetic opioids, other than methadone, have skyrocketed in recent years. And they are taking innumerable lives, usually young people, which is why I think this really matters. So I think what a lot of people wonder about is xylazine. This is a adulterant that's been in the news for quite some time now, past 5, 6 years or so. The question on a lot of people's minds is this cause for concern here in Colorado? And long and short is not quite yet, but probably soon. So xylazine is a horse tranquilizer. It's an alpha 2, so that's just fancy terms for this is basically clonidine. If you guys have ever used that clinically before or heard of it, and it's just supercharged and extremely potent. We saw a main surge on the East Coast. It's also been seen on the West Coast and is starting to encroach on our territory. It's increased from 2 to 26% from the early 2000s to 2020, so also an exponential rise. And we've only seen about 11 or so cases here in Colorado so far. And I actually met with the Colorado Public Health Agency a couple of months ago, and so far, it's very difficult to actually detect xylazine in our supply because there's no blood test that's easy to send. This is something that's a send out, probably takes weeks to come back. So we have yet to get the laboratory technology needed to identify these properly. So right now we just have suspicions. We're seeing most of it in more rural areas and not actually confirmed by laboratory test. Manifestations include skin ulcerations, which I'm sure you guys have seen on the news, and these can be seen not just with local injection, but with smoking, inhalation, or snorting as well. So
Can I ask a question?
yeah, absolutely,
Apologize.
yeah.
Sorry, Michelle Smith. I'm out here in Yuma County. I'm a sheriff's deputy. I'm also an EMT. Have been for about 19 years out in this area.
Great,
So
nice
the
to talk to you.
xylazine. So that is actually something I use on my cattle. We use
Yeah,
it as a mothering up drug for our cattle if we have one that will not take a calf because it does numb those senses and stuff like that. And you said that you're seeing it more in rural areas. Do you think that's where that rise might come from, or is there anything we can be more aware of?
Good question. I don't know where the drug supply is coming from. I think xylazine is being made in laboratories and synthesized abroad, much like our fentanyl supply. Our main two routes of fentanyl right now are from China and Mexico. East Coast is mainly getting the supply from China, and we are mainly getting the supply from Mexico. And laced in those pills is often xylazine. So my guess is it's being synthesized there, more likely than being diverted from husbandry or veterinary care or otherwise. However, I think we're going to learn a lot more about this. We tend to lag behind the East Coast in terms of what we see in the fentanyl epidemic. So I'm sure in the next, 2 to 5 years, we'll have a lot more data as to where is the xylazine actually coming from.
Okay,
That's a
yeah,
great
'cause, like
question.
right now, like I get all mine in it's obviously in liquid form because I give it as a shot. So not really to be concerned about that right now because I know like most vets will give me at least enough to treat 10 cattle when I've got 200 that I've got to do because on average I give about 5 of them xylazine by the time the year's over with.
Right. Yeah, I don't actually think that's of concern right now. I think the xylazine we are concerned about is the one that are in the pills. So more that powder formulation than the liquid that you're injecting the animals with. And I think it's a lot of people don't actually know they're using xylazine. Some people on the East Coast, especially, they're like, I use Trink Dope, and that was great. They love Trink Dope. That's the street name for xylazine adulterated fentanyl. But a lot of people don't know that's actually what they're using. So they find out after the fact when they start getting these skin manifestations, or they just have like a really bad time with what they were using. And then they test it and say, oh my God, that's what it was. So I don't think it's necessarily being intentionally diverted from that supply that you're talking about.
Okay, awesome. Thank you so much.
Yeah, absolutely. So this is just to illustrate that point that we see most of the xylazine in the fentanyl supply, greater than 30% on the East Coast. And it was pretty bad for a while. A couple of years back, I'm not sure if anyone saw on the news, it was like the zombie apocalypse sort of with the major skin ulcerations. And brace yourselves, you're about to see one right now. So they look pretty bad, to say the least. We don't actually know what causes these. We think that there could be some vasoconstriction, decreased blood supply to certain areas because of the alpha 2 effects on the blood vessels. We're just not really sure at this point. What's interesting though, it's not just the people who are IV drug users who are getting these skin changes. It's people who snort it, who smoke it. So we really don't know. At first I was like, oh, you're injecting into an arm and then you get this effect. That makes sense. But it's actually probably something much more systemic. So we might start to see more of these. So far, I've gotten calls about maybe 3 that were really suspicious. One was at Denver Health, but we have yet to confirm. So I think this is the real crux of the matter, though. Do the alpha 2 agents that we're seeing in the drug supply, because we're seeing a bunch of them, we're seeing Precedex, we're seeing clonidine, does it actually change management at the end of the day? Because, right, like it doesn't really matter what the etiology is of some kind of presentation. A lot of times it just means, what do we do with it? So the long and short is not really. The clinical effects you see with xylazine are clonidine, basically. You see a tired patient, you see bradycardia, maybe some hypotension, some skin ulcers. You treat them with fluids. You treat them with pressors if you need, and also typical wound management and antibiotics if it looks like it has a superimposed infection. So really you're just treating what you're seeing, and there's no magic antidote, there's no magic bullet, so to say, for these xylazine adulterant compounds. So I think that's really important to know and realize. Even if we are seeing xylazine, you're going to treat it the same way you would treat any patient. Any questions before we move on? Great. So that brings me to other drugs that are found in our fentanyl supply. So this is really interesting. We're doing a study at Denver Health right now where we take all the overdoses, opioid-related overdoses that we see in our emergency department, and we take a little bit of blood and test and see what drugs are in their system. And what we found is that there are actually a lot of amphetamines in our fentanyl overdoses. Which we didn't expect. We thought we would see some xylazine stuff. We thought we would see some other things. We didn't expect to see really potent amphetamine compounds. This could explain why we're seeing precipitated withdrawal. I'm sure you all have heard of this or seen it before, but this really severe precipitated withdrawal that we've begun to see recently, maybe it could be in part caused by the amphetamines that are within the fentanyl pills that patients are taking. So now let's talk just a quick second about one of my favorite topics, which is precipitated withdrawal. Precipitated withdrawal is not a new phenomenon. This has been around since the 80s. It actually first emerged when buprenorphine came onto the market, and a lot of addiction specialists were switching their patients from methadone to buprenorphine. What they found is patients would get a little anxious, a little sweaty as soon as they started the buprenorphine because they were pushing the methadone off the receptor. What the practitioners would do is just increase dose or abandon hope and say, bye, better luck next time. Now what we're seeing is a really, really severe phenotype of precipitated withdrawal, the likes of which we have never seen. My first case of it was when I was a second-year resident. We had a patient come in from jail who was induced on buprenorphine but had smoked fentanyl that morning. And we had never seen this before. So at the time, our team said, great, let's just keep going with the buprenorphine. And at the end of the day, we ended up having to intubate her. And she ended up on heroic doses of Dilaudid, propofol, ketamine for 5 days. So really, really severe. And we're not quite sure why. So there are a couple of theories. One is related to this thing called the ceiling effect, as you can see in the graph here. Basically, the idea is if you're on fentanyl every day, your brain is used to seeing a certain amount of, quote, signal all the time, a certain amount of euphoria, a certain amount of receptor occupancy. Then you give buprenorphine. Buprenorphine actually has a much higher affinity for the receptor, so it has no problem knocking fentanyl off the mu receptor. And then it brings that signal down abruptly that your brain is used to and triggers this very severe delirium. That's one theory. The second theory is that the amphetamines are in the supply. So in effect, what we're doing is pushing off all the opioid effect, tipping the balance, and now your body is just seeing all these catecholamines in a sympathetic surge. So my guess is it's honestly a combination of both things happening. But again, what do we even do about it? So precipitated withdrawal treatment, as you can see in this lovely kitchen design here, is a kitchen sink method. So if you have available in your rural areas, Dilaudid is always worth a shot. And the reason is Dilaudid actually has the closest affinity to the receptor as buprenorphine. So if you give enough, you might be able to outcompete it. But a lot of times we're talking 8 milligrams at a time of Dilaudid in order to try to outcompete buprenorphine. Fentanyl back isn't going to do anything because fentanyl actually has very low affinity for the receptor. It's very potent, but very low affinity, does not bind tightly at all. Morphine's not going to work. Methadone actually has horrible affinity. So the only opioid worth trying in these cases, if you're running up against it, patient got buprenorphine but smoked fentanyl that morning, Dilaudid is always worth a shot. And I always give my patients a shot with Dilaudid. Otherwise, you pretty much give your usual sedative agents. That means benzos, midaz, Ativan, pretty much anything you have on hand is worth a shot. Antipsychotics, sure, olanzapine. Maybe try alpha-2. Maybe start them on some clonidine or a dextrip or something. Ketamine, sometimes dissociative dose, go for it. These patients are very difficult to control. And if you need to, no one's going to fault you for intubating this like severely delirious patient because at the end of the day, it's a safety issue for yourself, your team, and the patient. Any questions before we move on to this lovely next drug? All right. So as you can see, we're going to be talking about crystal or methamphetamine. So I added this into the talk just because I think it may have been requested by some of y'all. It's honestly not one of my specialties, although I do see it a lot in the ED. I'm sure as all of you see in your jobs as well. And it's rampant, needless to say. So use and deaths related to this are obviously on the rise. They've gone up 20+% in recent years, and they're often laced in our fentanyl supply, these methamphetamine compounds, and they're especially used on the streets. People who are undomiciled often use methamphetamine to stay awake, to stay warm. So it's very much omnipresent. So in order to synthesize methamphetamine, this is quite interesting. It used to be synthesized by ephedrine, which, as you guys all know, was regulated starting in 2006 by the FDA. And since then, it's been started to be synthesized by P2P, which is phenyl-2-propanone. And this is known as supercharged meth. One of the theories as to why we're seeing the degree of delirium in these patients in sympathomimetic state that we are seeing these days is because of this synthesis method. It basically causes you to make one form of meth that's the most pure, potent form, whereas ephedrine, that synthesis way, used to make both a very potent form and a not so potent form. So now what we're seeing is this so-called supercharged meth since the early 2000s. Methamphetamine, it basically blocks all of your dopamine, serotonin, norepinephrine, all those monoamines in your brain. It blocks the reuptake and also increases the release of those catecholamines. So it's a two-pronged effect. So you just get a catecholamine surge effectively. And as a result, you get seizures, hyperthermia, and you could potentially see a severe cardiomyopathy. I've had patients come in, they're about 25. They have an EF of 10% or lower from chronic meth use. Now we think there probably is a genetic component, my apologies, to the cardiomyopathy because we don't see this in everyone and pretty much everyone's on it, but definitely keep an eye out. So if a 20-something is in heart failure and has the stigmata of such, it could be methamphetamine induced. The treatment for meth obviously is supportive care. These patients need to get cooled. So if they're hot, they need to get cooled. That's the thing that's going to cook their brain. That's the thing we worried about as toxicologists. Benzodiazepines still are the mainstay of care, but also pretty much everything else that you have in your arsenal. Antipsychotics, ketamine, just anything to get them down, because at the end of the day, you don't want to have any of that peripheral muscle contraction, energy generation, and then heat that could potentially cook them. Cessation is really difficult. I've looked into a lot of this as to like, how do you actually stop using meth? There's some papers talking about bupropion or Wellbutrin, which is also a cathinone. It's basically a bath salt derivative, not great data. Mirtazapine, some SNRIs, some SSRIs, not great data. So extremely hard to get off of and pretty useful if you're undomiciled. So this will continue to be an issue, I have no doubt, especially with the way it's being synthesized, and we'll continue to see more of it. All right, so let's move on to the fun stuff. We're gonna pivot over to psychedelics. And again, stop me if there are questions. This will be an overview of psychedelics, LSD, psilocybin, and beyond, as well as some clinical pearls and what I expect us to see in the future. So first, we're going to talk about psilocybin, one of my favorite topics. This is really hot right now. Obviously, everyone's seen it in the news, especially in Colorado. Colorado was the first state to decriminalize psilocybin. As you can see, the usual suspects are close behind: Oregon, Washington, New Mexico, California, etc. And there was actually a revision to Proposition 122 last summer, which is pretty interesting. So now people can cultivate mushrooms at home within a 12 by 12 foot space. So if you can imagine, that is a lot of mushrooms, like a ton. And you can technically give away mushrooms, but not sell them. But there are ways to get around that. You can now sell them under the guise of harm reduction, or if it is actual harm reduction, or just mental support. So there are these new wellness centers that are popping up all over and starting to take hold, where basically you bring your own mushrooms and then you can buy like a guide book and become a shaman and lead people through this. So the market is definitely evolving, and I think will continue to. So what is psilocybin exactly? So psilocybin, you can see on the left, serotonin on the right. So it basically has the same structure as all the things I was talking about: norepinephrine, dopamine, serotonin, these monoamines in your body that are involved in brain signaling. It just has this phosphate group on the top left. This is just a quick tox nerd moment to demonstrate why psilocybin has the effects that it does. And that's because it looks exactly like a compound in our body. Most of tox is hijacking the receptors in your body and the chemicals we already have to get high, I would say. So the mechanism of psilocybin, so it is an agonist at the serotonin receptor. This is the same one, as it happens, that's implicated in serotonin syndrome. And unlike MDMA, psilocybin only interacts with the receptor. MDMA is much more dangerous because it actually causes the release of the serotonin you have built up over time. So that's why you could potentially get the really bad hangover people talk about after using ecstasy the next day, because you're releasing all your serotonin stores. Whereas psilocybin just interacts purely with the receptor. It's not doing anything with your endogenous serotonin. So clinical symptoms are largely dependent on what dose you take. And this is just a quick reference for you all, but it really depends on everyone's brain chemistry. So for instance, 1 gram for me could be completely different than 1 gram for you guys. It's heavily dependent and heavily individualistic. So a low dose is roughly 1 gram of dried fruit, and that you can just get some euphoria and happy feelings, etc. A medium dose is considered 1.75 grams, and that may cause perceptual distortions. Now, I think that this is often misunderstood. A lot of people think that perceptual distortions are you seeing a unicorn dance about, or, like an overt hallucination. It's usually actually just like a distortion, truly. So like a wall sort of moving, maybe the ground going up and down, but it's not like you're seeing something that's not there. A high dose is 3.5 grams. You can get heavy, quote unquote, perceptual distortions. You can get ego dissolution. And then ultra high is 5 grams and above. And that you can disconnect from reality and have something called ego death. And these heroic doses, as we call it, are what's being used in cancer research with patients who are trying to let go of the fear of dying. We've actually really promising data around that, which is a really cool new realm for this. So psilocybin, is it dangerous? So the long and short is really no. And this is the main reason. You actually get something called tachyphylaxis with psilocybin almost immediately. Tachyphylaxis means that almost right away after starting to use mushrooms, your serotonin receptors start to go away, which means you cannot get physiologic chemical dependence from psilocybin. So it's impossible, basically, based on this fact, for patients to get addicted to mushrooms, which I think is quite interesting. The second thing, which I think everyone is thinking about, is can it kill you? And no, there's no identifiable LD50, which is the amount at which 50% of the time you die, your mouse dies or something. But it's estimated based on mouse data to be in the kilogram quantity. So that would be basically equivalent to a truckload of dried fruit in order to kill you. Basically, in effect, like you'd have to suffocate in it and drown in the mushrooms. At worst, you might just see some anxiety and fearfulness around this experience, because a lot of mushrooms is about your mental state at the time that you're dosing. So if you have baseline anxiety, then you could potentially have an uptick of this during your trip. It's actually quite promising for depression. So this is a New England Journal Medicine article. This was a phase 2 trial showing a reduction in depression scores at 3 weeks with a single 25 milligram dose. That's almost like a little, like tiniest little bit of mushroom. So very exciting. This is another study. This is a phase 2 double-blinded randomized controlled trial, basically really good trial. And what they showed is that psilocybin at 3 weeks had a greater reduction in their depression score than escitalopram, which is one of the SSRIs that we widely prescribe. And one quick comment about that, I'm going to get on my soapbox for a second about SSRIs versus psilocybin. I think this is exciting research for a couple reasons. One, just from a toxicologic perspective, is that SSRIs and SNRIs are not without dangers in overdose. So something like escitalopram or citalopram can actually cause QTc prolongation arrhythmia. Venlafaxine, I've had 3 deaths from cardiomyopathy in the last 4 months. Bupropion, I have more deaths from on record than any other drug in overdose. So what's exciting for me, at least, is that psilocybin does appear to be very benign with the data we have right now, and potentially extremely effective. So in sum, more and more people will be taking mushrooms. I can guarantee it. 12 by 12 space is a lot of mushrooms. It can cause anxiety and fearfulness at most, but you can treat that with a calming environment, like a little pat, put on some waves and ocean music. dim the lights. So some promising studies are showing favorable outcomes in treatment-resistant depression, which stay tuned, and more studies are in the works. And our Poison Center is really on top of this. We've started a whole data collection database for this, and there are multiple studies coming out shortly looking at all our poison calls from mushrooms in the past 5 years. So hopefully we'll have more and more information soon. All right, so if I was in the room with you all, I would be asking what you think this is on the right, but does anyone want to just like pop on the microphone and say what this thing is? Hopefully someone knows. No one really knows usually.
Stamps.
So this is, what was that?
Stamps.
Stamps, yeah. It's sort of like a stamp. So this is LSD blotter paper.
It's an acid tab.
Yeah, perfect. Thank you. Yeah. First one to get it in all my times giving this lecture. So bravo. Yeah, so this is called blotter paper. They're really small little pieces of paper with cool, fun designs on them that are impregnated with small amounts, usually 25 to 50 micrograms, tiny bits of LSD in some kind of carrier. Usually the carrier could be alcohol, it could be water, just some kind of solvent. And basically what you do is put the blotter paper, just one little square, under your tongue, and then you keep it there for a minute or so, and then you get high. So this is what you typically see. So we're going to take a moment to talk about LSD, because this is also in the news, and it's also being studied for refractory depression, PTSD, cluster headaches, I mean, you name it. So my favorite thing about LSD is honestly the history. I think it's fascinating. So LSD was actually synthesized from a compound you find in a fungus. This fungus is the same one that was implicated in St. Anthony's fire. St. Anthony's fire was something called ergotism, which is basically an affliction wherein patients back in the day, I forget, 300 something, way back, would eat rye that was contaminated with the fungus. And they would get these horrible skin ulcers, and some of them would get seizures. And then St. Anthony's was a bunch of monks who would take care of these people. And so that's actually the same fungus that produces the compound lysergic acid that LSD comes from. So really cool. So it was first synthesized by Albert Hofmann. He was a Swiss chemist in 1929. He was actually looking for an agent to use to wake people up from anesthesia. The company he was working for said, okay, we can put people to sleep, bada bing, bada boom. Now we have to wake them. So they were doing all sorts of things to lysergic acid from this fungus to try to make it something cool. And they accidentally found something called LSD-25. It was his 25th iteration of the compound that you see on the right. And one day, called Bicycle Day, on April 19th, 1943, he accidentally took 250 micrograms of his own compound. Now, for reference, again, in one blotter, you have 25 to 50 mics usually. So this was orders of magnitude greater than what our usual dose is. And he apparently had like a 3-hour experience where the world was collapsing around him, and he had quite the trip on his bicycle ride home. So that is the basis for LSD. After it was synthesized by this company, it was actually widely distributed to psychiatrists and addiction specialists all over the world to try to find a good market for it. There's actually some really interesting studies that came out in the 50s, really promising results for alcohol cessation and addiction research. And then in the 70s, it was attached to the counterculture movement and scheduled a class 1, and all the research was basically lost or buried. So we are now continuing to look into that. So this says just that, so I apologize. But yeah, usually taking in a very small amount, you can get visual distortions, euphoria. The difference between this and mushrooms is really the duration of action. So usually the duration for LSD can be up to 12, 18 hours even, whereas with mushrooms, it's about 4 to 6. So much longer, but very similar effects. You feel happy, the walls might move a little, and you potentially have a good time. The other interesting thing about LSD along the lines of mushrooms is it's exceptionally safe. There are promising studies, like I mentioned, for alcohol use disorder, promising studies for PTSD, depression, and again, you do not have the potential for chemical dependency based on the same phenomenon with serotonin receptors that we see with mushrooms. So then why do we hear about patients getting very agitated, very sick with LSD? I think this is in the news a lot. People are worried about LSD. Why is that? And that really comes down to this guy. The gnome is just because when I think emboom, I think gnome, but I don't know. I should probably revise this slide. Emboom is actually one of the most potent hallucinogens on the planet. It was synthesized in a lab years ago and is now pretty much in all of our LSD drug supply. When you take emboom, it attaches so tightly to the serotonin receptor with such fervor, it can potentially trigger serotonin syndrome. So this is where all the fear is coming from. It's because a lot of our LSD supply is adulterated with this. And so as a result, you could potentially have really horrible reactions. There was a professor talking at one of our national conferences. She was at Burning Man. There was a patient at the nearby tent who had taken a couple blotters and then needed to go to the hospital and dunked and paralyzed and all this stuff. Came back a couple of days later and said, "Where was that blotter paper? That was good stuff." So anyway, and then they tested it and it was emboom, in fact. There are some ways online that you could potentially tell the difference between this and LSD. One is LSD is colorless and odorless. Emboom is bitter and potentially has a bluish tinge to it when exposed to your saliva. So if you put it on your tongue and it's blue, then don't take it. And if it's bitter, also spit it out. So those are some rudimentary ways to try to tell the difference. There's also test kits online that if patients are using them or wanting to use LSD, potentially could encourage to use. They're sold on blotter as well as powders, and they're called N-Bomb and Smiles, and they just have a myriad of names. And there are case reports of deaths from the compound, probably from serotonin syndrome. So in sum, pure LSD, so not the N-Bomb kind, but the pure good stuff, is very safe, very potent. Again, dosed on the microgram scale. With mushrooms, you're talking about grams, so it's extremely potent. A lot of the drug supply is unfortunately contaminated with synthetics that can trigger a fatal reaction. And if a patient is agitated after taking a blotter or consuming this, benzodiazepines are always the mainstay of therapy. So that's pretty much it. And obviously, getting their temperature down is paramount because that's what cooks their brain. So that's LSD and N-Bomb. Any questions? All right. So let's talk about kratom. Kratom is pretty interesting, I feel like. I've just been reading. There's a website, if anyone's interested in what the kids are doing these days, called Blue Light. And it's like Arrowhead, but for the next generation. And it's a blog. And you can read about what all the kids are doing. And I've been reading a lot about kratom recently, and it's quite interesting. So this is just to demonstrate how present kratom is in Denver. There's this whole website, 13 best places to buy kratom. There was like 2 stores across from the Poison Center that you can just see through our windows. There's like 4 on my drive home. So this is growing and will continue to grow. So what is kratom? Kratom is actually derived from an evergreen tree that you can see on the right. And it's actually in the coffee plant family called Metragena speciosa. We unfortunately have to memorize these words for boards. It's native to Southeast Asia, and it's been used for hundreds of years as a stimulant. So if anyone's ever traveled to South America and chewed coca leaves, very similar effect. A lot of indigenous will chew kratom leaves in order to keep them awake for the work day, and then potentially take a different form of leaf in order to mellow out. It's been labeled as a drug, quote, drug of concern by the FDA, but has not been scheduled. If you go to their website, they'll say, we're looking into it, guys. Stay tuned. It's sold as powders, capsules, and tinctures, and there are white, green, and red types. So the white is actually thought to be more stimulating because it's a very immature form of the leaf. So each stage is a different color. So the white is the baby leaf, basically, and it has a different collection of compounds than the old leaf. So the white is more stimulating, the green is euphoric, and the red is thought to be more calming. And again, related to the age. The mechanism of action is interesting and also controversial. So mitragynine and 7-hydroxymitragynine are thought to be the compounds that exert the euphoria and other psychoactive effects. Both are partial mu agonists, which, if we remember back to chemistry days, is the receptor that is implicated in all of the effects of opioids, and also antagonists at other receptors. So it's sort of a toss-up at what they actually do. They also might have activity at the serotonin, dopamine, and other receptor locations. So safety. 1 to 5 grams is thought to be stimulating, so a pretty small amount. Greater than 5 grams is thought to be sedating, make you sleepy, and potentially opioid-like. And when I was reading on these blogs, it actually sounds like people are still using it to get off of their opioids. So a lot of people, like I read one where someone had gone from heroin to buprenorphine to kratom to bup, back to heroin to kratom. And he's now on kratom. And what he does is he doses himself with about 5 grams 3 times a day, and he's been staying off his opioids. So there's something to its opioid effects. We're just not quite sure to what extent. It's actually unclear if there's any risk for respiratory depression. There's actually one animal model that looked at this, and what they found is that oddly enough, the compound in kratom works through a completely different cellular downstream pathway than the compounds in opioids. And so in theory, it's absolutely impossible for it to cause you to stop breathing. However, dependency and addiction is real. We now recommend buprenorphine induction. I just actually inducted someone on the phone the other day for people who are addicted to kratom, and it works fairly well. So if someone is addicted, there is a way to get off. So in sum, the use is definitely on the rise. Shops are all over Denver, and they're popping up all the time. There are cases of death and respiratory depression, but all of them were unclear whether or not the effect was related to kratom or potentially the tramadol or other medications that were on board. Naloxone, always worth a shot. If you're in the field and a patient is down and has respiratory depression, and the only compound you can find around him is kratom, still back to basics, try naloxone. First of all, it has opioid-like effects, so who knows? And also, they could have an opioid on board in addition. And you can consider MAT, such as buprenorphine, for patients who have chemical dependency. So let's do a case to just mix it up. So this is a 23-year-old that I saw in the emergency department with a history of polysubstance abuse presented with agitation. Patient states he has been using a gram of fentanyl every day and a designer benzo that he obtains through a research science store on the internet. The patient has been off of this medication for 1 day and had a seizure. So this brings us to flubromazolam. Flubromazolam, or as I like to call it, Flubro, because it's too hard for me to say the full name, is what we call designer benzo. So designer benzos, like all benzos, are synthesized in a laboratory. No benzo is derived from a plant, like everything else we've been talking about. Designer benzos, though, are when chemists, and these people are so smart, I don't know how they figure this out, they put different groups onto the compound to make it more effective and more potent. So for instance, on the right, you can see there's a bromine and a fluoride. They pop them on the compound, this basic benzo compound, and it's extremely potent now and extremely effective. So they're always altering these compounds in order to appeal to their market. It's actually a member of a class of benzos called triazobenzos. So that speaks to the group on the far top, which is all those nitrogens. And that's called a triazole group. Basically, this group is very of interest to us as toxicologists because it's the same one found on Xanax. And so as a result, patients who are addicted to Flubro, who are in withdrawal, might only respond to Xanax, which is interesting. Now, I don't think this is really of import pre-hospital. If you ever have a patient pre-hospital who's withdrawing, benzos, anything you have, withdrawal seizure, midazolam, Ativan, all the good stuff. But once you get to the ED, something we might consider based on this structure is giving Xanax back because other benzos might not do the job. So this is the one case in which structure matters. So if you ever have a patient who says they're on a designer benzo, looking up, taking a quick peek, seeing if this is the structure that is on if this structure is on the big molecule, it could potentially be of clinical import. So just a word. Also, the designer benzos are popping up every day, like daisy. There are new ones on websites like pretty much every second. People are working hard to create these, and there actually been waves of this kind of thing for years. So remember, there was like the synthetic cannabinoid wave of spice and all that stuff, and people were getting really crazy. That was back in what, the 2000s, early 2000s. Then you have the synthetic like opioid wave that we're experiencing, and they're popping groups on fentanyl and making it crazy. Now we have the synthetic benzo wave. So no matter what, people are always altering these compounds in order to make them more potent and even crazier trips. So we will see another wave. I don't know what it'll be. So in summary, this is a very potent benzo. They're very highly addictive, these compounds. Structure matters might mean that other benzos don't work and might be worth a trial of a prazolam, but you might have to switch to Xanax. All right, we're going to talk about GABA compounds because these are some of my favorite, and you'll see them on the streets quite a bit and probably more and more in the future. So does anyone know what this is? Clear, odorless, and looks like water, but it's not water, and it'll put you out.
Ether?
Not ether, but this is a compound. Say a patient's at a club, they're dancing, and they get handed this, and they're maybe drinking, and then they come in, and all of a sudden they don't have a gag reflex, but they're alive. Okay, this is GHB, gamma hydroxybutyrate. This is one of my favorite things to talk about. I think it's pretty fascinating how it works and what patients look like. So this is actually a GABA B agonist. Everything else we deal in the ED is always, or pre-hospital is always GABA A. So ethanol, benzos, those are like clear-cut GABA A drugs. This is GABA B. GABA B is really, really tricky. This is what makes GHB and other GABA B agents like phenibut and baclofen really tricky things to treat in overdose, really tricky things to treat in withdrawal. And that's because they have presynaptic and postsynaptic receptors. So in effect, it has excitatory and inhibitory effects. And so depending on what course the patient is in the natural history of their disease, you could see completely opposite clinical manifestations, which is pretty fascinating. This compound is colorless and odorless. It's a liquid. It's used in the club scene and for chemsex, which a lot of agents are used for chemsex, such as poppers. They're smooth muscle relaxants, and you could probably find them in any shop on Colfax or South Broadway. It's euphoria inducing. And the FDA actually approved GHB for narcolepsy. So, narcolepsy, you have like this whole sleep-wake issue and your entire circadian rhythm is disrupted. And you can take GHB in order to put yourself to sleep, basically. So patients will take it right before bed, and then they will take it 5 hours later because it's extremely short half-life. So it's used for that. Overseas, it's also used, I think its name is like Styrem or something. It's approved for alcohol cessation, works quite well for that. But so far in the US, we are slow to adopt that. So history is everything in these overdoses because you're never going to get a confirmatory blood test. Well, I'll never say never, but pretty much never. You'll never get a confirmatory blood test. You'll never get a confirmatory urine test. So all that you have is history to go on. And that's because it's very short acting. It only lasts in the urine for 10 hours. So say you drank it, then you're in the club, then you go down, then you get taken by EMS, then you're in the ambulance. I mean, needless to say, you're not going to pick it up on a urine drug test by the time you actually get one. So context is key. Club goers, this is the population, especially in the LGBTQ community. It's very popular drug abuse, and especially overseas. So in Europe, especially Berlin, the nightlife there, you'll pretty much see GHB around every corner. So the natural history of the toxin is quite interesting. When you take it with alcohol, you pretty much stop breathing. Weirdly enough, if you take it on its own, you maintain your respiration. You go down, you're in a coma, but you potentially are still breathing. But a lot of people are drinking in these clubs, so inevitably you're going to have both on board. You also have some brain death like signs. It's a brain death mimic. We have a bunch of things in the talks where you lose all your you lose all of your reflexes, like your gag and your corneal and things like that. And so this is one of those. You potentially come in, you have no gag, you have no corneal, like the patient appears dead for all intents and purposes, but they still have a blood pressure, they're intubated, they go upstairs. Patients usually get intubated by the team, then pull their own tube at 5 to 6 hours, and that's based on the half-life. Half-life is about 45 minutes, so if you assume 4 to 5 half-lives until the drug is cleared, 5 to 6 hours, then they all go, like sort of wild tigered out of the ICU. The other population to be aware of with GHB are bodybuilders, and that's because these GABA B compounds supposedly promote slow wave sleep, which is the time when you sleep where you secrete growth hormone. So a lot of bodybuilders use it in order to bulk. So sometimes you'll have a patient come in, one of my co-fellows loves to bring this up, who's really jacked and goes down, gets intubated, and gets extubated. And just, you have to beware because your staff has to wear like this huge dude basically, or maybe bodybuilding woman, are like leaping out of bed and like, can be quite scary. So in sum, it's basically impossible to identify this drug, which makes it perfect for drug-facilitated sexual assault, unfortunately. It's one of the most commonly implicated drugs. The most common drug for drug-facilitated sexual assault is alcohol, obviously. But this is the third or maybe even second now most frequently used drug. History and context will cinch the diagnosis every time. Just pay attention. Where did they come from? What kind of situation? Was it a club? Etc. There are no specific antidotes or therapies. It's all supportive. Intubation if you see fit. If a patient comes out and they don't have a gag, I wouldn't even pay attention to the nuances of, well, maybe they're breathing and maybe their minute's okay or whatever. They tube them, totally fine. That tends to happen with most of these folks. It's highly addictive, and there aren't many treatment options. So unfortunately, GHB, because of its GABA B nature, etc., one of the most addictive things we have out there. And the withdrawal from it is horrible. It lasts for about 3 weeks, whereas alcohol rates like 5-7 days until your withdrawal goes away. But it lasts about 3 weeks, and patients enter treatment programs, and then there's an 80% relapse rate. And oftentimes the withdrawal is accompanied by debilitating depression, anxiety, and a lot of mental health issues. So this is a very hard population to treat. Overseas, they have GHB readily available. They do tapers with it, which actually works a lot better. Here we give them benzos, which doesn't do the trick. Because remember, benzos work through a different receptor. So they don't quite hit what you need it to. And so patients often go out, relapse, and end up using even heavier by the end. All right, one more. I don't know why I thought this was funny at the time, but one more GABA for the people in the back. So this is Phenibut. This is something we might start seeing more and more as well. This is liftmode.com, and I just quickly Googled it, found it within 5 seconds. This is Phenibut 300 milligram capsules that you can buy for $35 and ship it everywhere, basically. And it's used mainly for bodybuilding. This is also a GABA B agonist. I may have to see a second. Oh, no, we're good. This is also a GABA B agonist similar to GHB. And so because the thought is it increases your slow wave sleep, a lot of bodybuilders are using this in order to promote growth hormone release. The last patient I saw with Phenibut, usually they come in a withdrawal. You really don't overdose on this. Last patient I saw withdrawing from this came in after a seizure. He had been using it for like months and months and months in order to bulk. Baclofen actually works really well for the withdrawal from this. There's actually an online baclofen to Phenibut conversion that you can use. I think it's like 10-to-1, and you can taper patients with baclofen in order to get them off. Otherwise, benzos for seizures, what else is new, and supportive care in the ED. And that's Phenibut. All right, so now for something really scary. Unfortunately, bring the mood down a little bit here. This is something that we're definitely going to see more of. I'm sure you all have heard of. There's been public service announcements, Arapahoe County and various other parts of Colorado about sodium nitrite. Does anyone in the group know about this or heard or seen a case about it? No? Okay, so as you can see, this looks like salt, right? And it actually is. So sodium nitrite is curing salts. They're used for meats and other products in order to preserve them. You can get a whole bag on Amazon if you quickly want to Google for like $20 and you can overnight ship it. Problem is, there's actually a new suicide fad online where kids will take a bunch of the salt in order to end their lives, and then they do. So there are even suicide kits being sold on the internet and on Amazon. I think they were banned recently, but it was a major concern a few months ago. There was as I mentioned, an Arapahoe County public health warning to providers in July, and we had 2 deaths around that time. So what's scary about this drug? So I'm sure everyone's heard at least the name methemoglobinemia. Basically, methemoglobinemia is a condition in which your hemoglobin, which usually carries oxygen, cannot. And that's because the drug in which you've consumed converts the iron moiety at the center of your hemoglobin to Fe3+, and it cannot bind to oxygen. So actually what happens in methemoglobinemia from things that convert it to the Fe3+ form is that you have enough oxygen in your body. You're actually like full of oxygen, but you can't actually deliver it to the organs that need it. So that's the real issue. So in effect, you have an anemia. You have a poor oxygen delivery problem, and so you get more and more hypoxic effectively. Sodium nitrite compounds are very, very scary because they're extreme oxidizers. They do this reaction as fast as, you can blink. They're converting every single hemoglobin in your body to this, so you can't drop any oxygen off. And they can result in levels of 70%. So imagine a patient comes in, their hemoglobin is 14, 70% of that is not useful. So you don't really have any. And patients die from essentially asphyxiation within minutes. So this is a very, very scary thing. I think we're going to see more. It's so readily available. It's in restaurants. It's online. So yeah, beware. But now let's talk about what can we do, because that's the most important thing. Like, how can we actually save these kids? Well, first, we'll pause for clinical signs. Sorry. So early on, patients can look gray. This is the classic finding of methemoglobinemia. That's just because methemoglobin is like bluish gray color, so you just get that look because of the color of the blood. Then you get signs of progressive hypoxia, right? You can't deliver oxygen. You get short of breath, you get chest pain, you get somnolence, you get a seizure, you go into coma, and then you die. The problem with sodium nitrite is you might not see this nice progression because of how fast it's exerting its effects. So you might just see a patient go down and cardiac arrest. The treatment is methylene blue. I think there's some moves to get this on buses for pre-hospital providers, but so far it's only in the hospital that we have this available, which I think we're working on because it's very benign. Like, this is a very benign antidote, and we need to give it, and we need to give it fast in these cases. So if you get the clinical story that a patient has taken salts from a friend or a text message and they're down, quickly as humanly possible. So my advice is immediate supportive care. So oxygen on. You need to get IV access so you can actually give this antidote and race to the hospital, because time to this antidote is key, and that's what's going to save lives. Sometimes you need to give it before you get labs back. A lot of times in the hospital, we have the luxury of getting a co-oximeter, which gives us a methemoglobin percent and can tell us how bad things are. But a lot of times all we have is history to go on, and we need to give it empirically. I also encourage people to start high in these cases. 2 milligrams per kilogram push, repeat after 10, maybe repeat a third and fourth time if you need to. 8 milligrams per kilogram is the theoretical max for methylene blue, but if someone's sick, all of that goes out the window. The final thing that's always an option in these cases, so say you can't get to the hospital, patient is dying, is blood. So giving blood to these patients, or say the hospital doesn't have methylene blue, giving blood will give hemoglobin that is actually untouched and has the Fe2 plus from the donor. And so just giving it back will help the patient immediately. So that's always an option if you're up against it. In the case we had a cardiac arrest. It was like a 15-year-old who took it and then got to the hospital. We gave 3 doses of methylene blue and then we started blood transfusion, but unfortunately it was too late. Okay, let's end on a like sort of nice note, quote unquote, or like less sad note. Poppers. These are similar compounds to sodium nitrite, but they're not as bad. These little guys look like 5-hour energy. So the poppers on the right, 5 hours on the left. You can get them at gas stations. And they're very popular in the club scene. And again, for chemsex, they actually induce smooth muscle relaxation. Problem is, usually you're supposed to inhale them to get high and cause smooth muscle relaxation. But a lot of people don't know how to use their drugs. So unfortunately, they drink them. And when you drink them, you get methemoglobinemia, just the same as sodium nitrite. The good news is a lot of times patients aren't as sick as their sodium nitrites. They come in from the club, maybe their level's 30%, but they usually do just fine with a single dose of methylene blue. And then once they're stable, looking good, and their level of methemoglobin's back down to a normal range, they can be discharged. So this is a manageable group of patients. It's not as scary, but it is important to put oxygen on, get IV access, supportive care, get to the hospital for the antidote. If patients with methemoglobinemia don't get the antidote, there is a potential they'll do fine anyway. Your body actually clears methemoglobin endogenously at about, I think it's like 5% per hour. So if they have enough reserve, they're a young person, they don't have any baseline comorbidities, and they have time to be mildly hypoxic, they will clear their methemoglobin. It's just those who can't quite handle that much hypoxia for that long that really need the antidote. So guys, that was shorter than I expected, but thank you all for sticking with me. I'll go back to the slide with the barcode, and then I'm here to answer any questions you might all have.
I got a question about the salts piece. The salts, is bath salts in that category of drugs?
Actually, yeah, good question. So bath salts, actually, you know what's interesting? Bupropion is a bath salt. So bath salts actually are a colloquial term for a type of amphetamine. So they're actually, and another bath salt is khat. Have you guys heard of khat before? It's a plant in Africa that people chew on, and it has the same amphetamine structure that we talked about with meth. I didn't bring that up, but it's basically the same thing. And so patients will be like extremely agitated and all sorts of weird things happen because of how agitated they are, as we've heard. And so that's bath salts. And bupropion is the only FDA approved bath salts, a cathinone. And that's why with bupropion, you see patients in overdose get sympathomimetic, agitated, tachycardic, hypertensive, because it's a bath salt. The salts I'm talking about are actually salt. So like table salt, like that's closer to what I'm talking about. It's a curing salt that basically preserves meat and helps to keep the meat over time, and people are ingesting that. So very different, but really good question. All right, guys, any other questions? If not, I can sign off here, but it's been a pleasure. And I'd appreciate any feedback on this lecture, and I appreciate all of your time.